So holding on to the theme of the resource-constrained austere environment, we're moving on from what you should do to your trauma patient in the first minutes to hour to what you have to do to take care of them in settings that are longer than the time frame that we're comfortable with in the emergency department. So let's continue our case. So unknown extraction evacuation time, can't land a helicopter as it's too dangerous. So in reality, the soldier ended up waiting for about 15 hours to be extracted, and they unfortunately died of their wounds before they could be extracted. But in this scenario, what new considerations are there? What downstream pathology do we have to be aware of and account for? So let's go back to Fort Francis. So same teenager as before, jumped off of that building, polytrauma patient. The nearest trauma center with surgical support is Thunder Bay. So on a good day, that's 4 to 5 hours by orange helicopter. But as we know, if there's weather or if it's nighttime, then this will take a little bit longer. And it's actually not uncommon in this scenario to have to board this patient overnight in the ED. So you've completed your TCCC, you've done your ATLS, what comes next? How do you package this patient for transport? How do you provide care for them in the prolonged setting? So prolonged field care, what is it? Before the term PFC was coined and a working group was formed, there's no real concerted effort to study or standardize the care of casualties in the operational environment over prolonged periods. Prolonged field care happens after TCCC when evacuation to higher levels of care is not possible. So PFC is holding on to a sicker patient than you can care for longer than you want to, with fewer resources than you need, in a place you don't want to be. This doesn't just happen in the operational setting, and if it feels like you, we've all been there. The official definition is field medical care applied beyond doctrinal planning timelines, utilizing limited resources. So simply, it's applying holistic, evidence-based medicine in the management of complex patients over extended periods of time in resource-constrained austere environments. It's important to note that you don't plan to have PFC. If you're prepared for it, that's better. But if your plan includes PFC, you need to make a new plan, basically. It's like survival training or mass casualty training. You never plan to be in it, but you prepare for it. So why do we need this? In the civilian context, we need it because PFC can happen to anyone that practices outside of a trauma center. It's an all too common scenario that critically ill patients become critically ill outside of a large metropolitan area, and there are delays to timely transport. Outside of the bubble of tertiary care medicine and level 1 trauma centers, considerations such as available personnel, resource utilization, available skill sets, surgical capabilities all come to the forefront. And as specialists, just like ourselves, like to flock to or stay in large metropolitan areas, that leaves more responsibility to our rural colleagues in terms of these cases. In the military context, why PFC is needed, as we transition from conflicts with mature and developed medical infrastructures like those that we saw in Iraq and Afghanistan to what we're facing now, which is small teams of special forces over large areas, the ability to provide medical care in a timely fashion is greatly hindered, if at all possible. In these contexts, just as the military providers are the only medical providers available to their casualties, our rural ED colleagues are often the only medical providers available to their casualties as well. So if we do just a quick size comparison, take a look at the size of Iraq and Afghanistan, the amount of infrastructure, soldiers that were required to provide timely care there, and the areas that we're now operating in, you see a huge discrepancy. And if we do the same comparison, think about all the paramedics, all the infrastructure that's needed in Ottawa to get good, timely transport, and compare that to the landmass of the rest of Canada, the landmass of the rest of the states, we see how thinly our rural colleagues must be spread out and why these delays exist. So what is the fix? What is the solution then? If you can't bring the patient back to your tertiary care center, you have to push that capability forward. He addresses this operational constraint, and it's got numerous parallels to rural practice as well. The solutions that are most readily available being increasing training in austere critical care and evacuation capabilities, or providing access to expert consultation in real time. So we'll talk about each of these as they both bring the expert to the patient. Just like everything else that we've talked about, PFC is organized into an acronym There's a staged approach. It's organized and conceptualized into ruck, truck, house, and plane. So the stages are unique to each mission, but they're pretty self-explanatory. So ruck is the amount of gear that you can carry on your person. Truck is the gear that can only be supported on a team-based vehicle. House is equipment that must be cached in a support base. And plane is anything you have access to during evacuation. So the important part here is the framework. Planning and a shared understanding between boots on the ground and the command infrastructure as to what medical capabilities are possible at each stage of a mission. So similar considerations and principles are used when you're stocking rural EDs, ambulances, when you're planning for expeditions. A detailed understanding of capabilities is required for proper planning across a system. And having this common language allows a groundwork for collaboration. So, now that we understand the purpose and the structure of prolonged field care, what are the must-have pieces of equipment for the austere medical provider? I'm going to be a little controversial here, and I'm going to argue that you can provide near ICU level monitoring in a backpack. In terms of management, you definitely cannot. You're going to run out of supplies, and you need to move to a phase of care where you can cache those supplies, or you need to stock your rural ED accordingly. But near ICU level monitoring in a backpack sounds crazy. Bear with me and think about this. What are the most important pieces of information that you use to make clinical decisions for a critically ill patient? It's not the fancy stuff. It's the basics. It's vital signs, mental status, neurologic status, organ perfusion, with one window to that being your Foley catheter and your urine output. The most important aspects of critical care are diligent one-to-one monitoring, so vital signs monitoring, catching things early, and clinical expertise. One of the big reasons that people are moved to the ICU in our setting is for increased monitoring. And we can do that if we can dedicate the time. So if you're in this scenario, hopefully, if you're that rural ED provider, that single coverage ED doc, you've thought about this, you've thought about the prolonged care scenario, and you have backup available. The goal here is to trend vital signs. Early detection of badness is key. Gradual, subtle changes can be intervened on early. So you're going to use these low-tech tools to prevent high-tech interventions. So what are the skills then, the 10 essential capabilities that you need to have in order to provide austere medical care? These are the things that any austere medical provider should be able to accomplish, and it should go into the planning of any of your expeditions, transports, your rural ED. You should have the supplies to do these things. So there's 10 of them. We'll talk about 3, 3, and 4, with the last 4 being the most important. So you want to be able to monitor your patient to create a useful vital sign trend. All of these are divided into minimum, better, and best, with the recognition that you're not always going to have all the gear that you want to have. So better is going to be capnometry. Best is going to be if you have a vital sign monitor that does it for you. In terms of resuscitation in the military and trauma context, your minimum is going to be fresh whole blood transfusion. And you're going to move on from there. If you have head injury or burns, you're going to want hypertonic saline and other maintenance fluids. And your best, which is what most EDs have, but not all, and this is a consideration, having a stock of blood products. In terms of ventilation, you want to at least be able to provide BVM with PEEP. Supplemental O2 and a portable ventilator would be best. In terms of airway, we kind of briefly talked about this, but your ketamine crike and RSI capability would be our best. In terms of sedation, you want to be able to provide IV opioids, ketamine, all that good stuff to accomplish the rest of PFC. And in terms of physical exam, we kind of have this down pat. The most important things being things that we can actually bring with us. So POCUS being a very important skill here. And POCUS in special forces being a very evolving area of research right now. Last 4 are the most important because they're the ones that we're least familiar with and the ones that we least practice. So I'm going to argue that number 7 is probably the most important and the ones that we're least comfortable with. In the prolonged care setting, you have to have nursing skills. You have to be able to keep your patient clean, warm, dry, padded, catheterized, basic wound care. And from there, debriding wounds, washouts, dressings, decompressing the stomach. And being experienced in that is going to be what's most difficult for our context of a provider because we don't do this on a daily basis. In terms of surgical things, chest tube and crike are your minimum. But in terms of austere medicine, you're going to be called upon to do things that you're not comfortable with. These are like fasciotomy, escherotomy, wound debridement, amputation, lateral canthotomy. Telemedicine we're going to talk about in a little bit in detail, but having reliable communication, being able to transmit information, and then packaging your patient for transport. So having a knowledge of what the physiologic stressors are, and if you have training or experience in critical care transport, that's going to be your best. I bet you didn't expect another acronym. There's tons of acronyms here. But just to summarize our prolonged field care: resuscitation, reduced tourniquets, airway and cric care, ventilate and oxygenate with a lung protective strategy, initiate telemedicine and evacuation early, nursing care. So again, to emphasize this includes monitoring and trending vital signs, ins and outs, head of the bed up, DVT prophylaxis, turning your patient, passive range of motion, oral hygiene, all super important in the prolonged care setting. And that feeds into that are environmental considerations. So hypo and hyperthermia, chapstick, sunscreen, padding pressure points, motion sickness prophylaxis, all that good stuff. And then your surgical procedures. So to just summarize all of that, we have our overall approach so far. We had a whole bunch of acronyms. We have our March algorithm, our PAUSE-B, and our ravines. So how does that all fit together? So we start with our S, which is shoot back, gain your fire superiority, and make sure you're safe. And from there, we move into our March algorithm, so addressing the life threats. From there, you're going to take a step back, do your vital signs monitoring, get some trends. You're probably going to go back and reassess your March algorithm. And then you move into your PAUSE-B. Then you take your therapeutic pause, you do your complete secondary survey. You generate a prioritized problem and intervention list. And then you move into prolonged field care and the ravines algorithm. So, last two things we're going to talk about are documentation and telemedicine. There are documents that have been floated around. If you guys have had a chance to take a look at them, now would also be the time. The most important aspect of prolonged field care is documentation. And that's for three reasons, just like everything else in this talk. It allows early recognition of badness, shock, sepsis, organ dysfunction. It allows problem list creation and intervention prioritization, and it allows complete, concise handover and transfer of information. So wouldn't it be nice if every time that we received an interfacility transfer, we had a clearly documented clinical course on a universal form, easy to read, easy to use, familiar, and accessible to us. So we don't have to sift through piles and piles of mostly useless information to try to figure out what has been going on with this patient. Can our interfacility transfers be streamlined and improved? So let's take a look at how the military does it. So in terms of our minimum, that's our TCCC card. Our better is going to be our PFC flow sheet, and our best is our telemedicine guide. So we'll go through each of these guys. So in terms of our TCCC card, designed to be used under stress, simple, succinct, fast, easy to complete. So we'll highlight here the salient points. So it runs on the ATMIS algorithm, which we'll go through. So there's age, sex, timing, mechanism of injury, injuries themselves with an annotated diagram, signs and symptoms, and treatments in a March algorithm type fashion. So the timings of all key interventions are there. You have an annotated diagram. The civilian application of this is that this is the same acronym that's used for pre-notification guidelines for paramedics. When you move from TCCC to PFC, you move from your TCCC card to your PFC casualty card. So this allows trends over time and is useful for recognizing important clinical changes in complex patients. It's got two sides to it. This is the first one, and we'll go through what is included here. So it's got all of your vital signs, your fluid ins and outs, your neurologic exam, medications and intervention timings. Not only does it serve to document and identify trends, but it also contains a checklist of patient care and nursing interventions that may be needed throughout the prolonged field care setting. The backside there has a sample history, physical exam findings with an annotated diagram, problem list, treatment plan, which is prioritized, the mechanism of injury up here, and an area for notes. So the important part of these two documents is that they're familiar to everybody who uses them. So if you want that information, you can look quickly at it, and you can see exactly what you want to know, which is something that we could emulate in the civilian context. Last thing that we're going to talk about is telemedicine, aka consultations, how the military does it and what we can learn from that. So consultations are an everyday aspect of our medical practice. The idea behind telemedicine is it allows the medical provider who is physically with the patient, through input from an expert that is off-site, to deliver care without having to train this provider to the level of this expert. So it brings the capability, the expertise to the patient, expanding the catchment area of those that can receive specialist care, and it temporarily increases the scope of practice of the receiving provider. So let's look at how consults are done in the military for ways that we can streamline our own consultation. So again, the military context is high threat, high risk, complex patients, so being brief and being concise are super important. So we have our minimum, better, best. So our minimum is going to be voice plus or minus some type of media. Our better is going to be voice with media, email, photo, and our best is going to be some type of video teleconsultation with remote diagnostic monitoring. Brainstorming ways that this should apply to us, and kind of is already, but should all pages in TOH come with an MRN attached so that our consultants can review the imaging, review the consult, review all of the information before they get on the phone, decreasing talk time and increasing the conciseness with which they can give us advice. This is mostly solved through Epic, I think, though we do kind of both at the exact same time. It would be ideal for us to be able to give them a little bit of lead time, but something to consider. So should all outside calls that come to us be preceded by a clinical summary with labs and imaging? Again, people are going to say this interrupts flow, takes up time, but I'm going to say if this guy can do it in a combat setting, we can take the time to do that as well. And just as in their context, video teleconference gives you more information than just voice communication, should our equivalent, which would be the in-person consultation, be used more frequently? So for our complex, critical patients, should we bring that consultant to the bedside and perform the handover and the consultation there? A bunch of little nuggets to think about. It's interesting to note that in the military context, rehearsal of telemedicine consultation between providers and remote consultants has shown that communication is optimized when that caller uses a telemedicine script and uses that during the consultation. So should we meet with and discuss with our consultants how they want information presented? Just as consultants' responsibility is to diligently consider the case and offer input and expertise, it is our responsibility to logically present that case and give them the information that they want to hear and need to know in order to take action. And we can do that by speaking the language of the consultant and asking a clear clinical question. So just as our patch phone scripts between us and the paramedic, should we standardize the format in which we perform our consultations so nobody ever gets lost in the information that's presented? The important part here is presenting that information in a way that is familiar to both parties involved. And so you can argue that with our level of training, with the level of training of our consultants, that it's always a familiar context. But as we know, through experience and through anecdotes, the quality, organization, and presentation of consults received and given varies. And there's definitely room for improvement. So this is how the military does it. There's another acronym. It's PREP. So you want to prepare. So you want to develop a hierarchy of who to contact. So in our context, super simple, junior, senior, fellow, staff. But if you're in that rural context, you call your one general surgeon on call and they don't pick up. Then what? Once you've figured out that, you want to rehearse presenting your consultation in a format that's familiar to both parties. You want to recognize when you should call. So this is when you have a clinical question that is beyond your scope of practice. And you want to recognize your limitations and call before things get a lot worse. In terms of execution, you want to send available patient information, flow sheets, images, everything you have ahead of time. And then you want to perform your consultation from a script or a format that's familiar to both parties. And in terms of performance, that's going to be your quality improvement type things, understanding the capabilities and limitations of your service, and performing after-action reports. I don't know that we formally train or test the ability to consult consultants, despite coordination of care being arguably one of our most important skill sets. In terms of the actual information that you want to get across or that you want to receive, three main things. So that's live input. So that's what you need to know right now. What do I need to do to save this patient's life? What do I need to act on now? You want anticipatory input. So what do I think is coming down the line? What do I need to prepare for? What do I need to follow up on? When do I need to follow up with you? And the last thing is your capabilities. So these are things such as level of the provider, available medications and equipment, available monitoring, if you have surgical support or not. This is like being on the other side of the patch phone and knowing exactly what ACPs and PCPs can do and giving them advice based on their capabilities, not telling them to do things that they're not allowed to or cannot do. So should there be a standardized format to inform us or to inform our consultants of what our capabilities and limitations are? Could there be like a photograph or a database that's apparent for, because I don't know, for example, what can Armprior do? What can Renfrew do? What can Pembroke do? What support do they have? And if I offer advice to them that they say, well, I can't do that, it's wasting everybody's time. So the lessons that we just spoke about were all gleaned from the implementation and iterative improvement of the virtual critical care consultation service. So this was developed in 2015 and tested extensively through field training exercises as well as live real-world encounters. And it basically provides on-demand critical care support to medics anywhere in the world 24 hours a day. So staffed 24 hours by an intensive care doc somewhere in the States. And medics can get to it through one telephone call, one email. And there's an email distribution list so that everybody involved in the service is appraised as to what's going on. The script itself is broken into 5 sections, and I think it's a great example of what a telemedicine consultation, what any consultation should look like. So we zoom in again. We have our introductions and callback information. So how many times have we been on the phone, we lose connection, then we have no way of getting back to that person. We have to call critical again. We have to jump through all the hoops. We have our clinical history, our problems, treatments, and the actual question that we are asking. We have our vital signs and physical exam. We have recommendations, either prioritized by priority or by system. And then we have a to-do list and follow-up instructions. So you'll notice that at the end of each section, there's a pause point designed to allow either the caller or the consultant to clarify any questions that they have and review the information that was presented. And the section on capabilities down here at the end is meant to be sent 10 to 15 minutes ahead of the phone call itself, though in reality they usually send the entire thing so that the critical care consultant can review the case before getting on the phone. And so talk time is found to be decreased with that, and the conciseness with which they provide recommendations is improved with that as well. So that's our review of prolonged field care, its applications to civilian practice, and its emerging role in military medicine. I hope now you'll be able to integrate a holistic and evidence-based approach in the prolonged care setting. You'll be able to optimize your communication through formats familiar and useful to all the parties involved, and you'll be able to avoid any pitfalls in teleconsultation. All in all, we've learned kind of a new alphabet here. We've gone over the basics of both TCCC and PFC, their numerous applications to civilian medicine, and I hope you've gained an appreciation and I've been able to show you the relevance and importance of understanding how our military colleagues practice. So jumping back to our take-home points from the beginning, through an understanding of tactical combat casualty care and prolonged field care, you're now able to apply an organized approach to your next critically ill trauma patient. You understand the pre-hospital options for junctional hemorrhage control. You can integrate a holistic and evidence-based approach in the prolonged care setting, and you can avoid the common pitfalls of teleconsultation. With that, thank you for listening, and I'm happy to take any questions.